Hello, good day, my dear friends. Today I'm back again with another topic of interest for your exams is male infertility. We as students, we as students, okay, I've gone past to the same phase, is we get MCQs, EMQs and short notes on male infertility, and we find the male infertility as a topic to be very confusing and very advanced level. But I can tell you, I can promise you this is not going to be very advanced level stuff. It's going to be very simple. I mean, talking about bare necessities you have got to get in your head for your exams. This is basically exam reckoner. So just before the exams, just go to the video. You can often increase the speed of the video and just cut through some of the BS stuff I'm often blur out. Okay, but again, before we go to this case presentation or my slide presentation, please subscribe to my channel if you haven't done till yet, and please like my video and share it with your friends. Obviously this is meant for sharing of knowledge just before your exams. Okay, so let me share my screen now. So here am I with a male infertility. Okay, so if you're not in my Facebook group, so there are many people who will be interested in male infertility. We always give a lot of information in our Facebook group. It's called the Male Health Online. I will be posting my links also. So all of you want to have a normal discussion on what the case studies will be, what is infertility, what are the problems of infertility, male health issues. You can always, you're ready to join my Facebook group. Okay. So without wasting any time, will say that nowadays it has been seen that male factor infertility is 40% of all infertile couples. So this is 60% is the females. The most common obviously is the ovulation disorder. 40% of males. What is definition of infertility? Is defines the lack of conception following 1 week of frequent unprotected intercourse. Okay, that's very important. So even so, what are the subtypes? You have a primary infertility where a couple had a pregnancy, somehow it got lost due to miscarriage, but later on the both of them are unable to have a conception. So that is called secondary infertility, but the primary infertility is never ever conceived. That's the difference, primary versus secondary. Okay, now we'll come, this is the agenda of today's talk. We'll talk about everything in detail in short. We'll try to be very short just for the exam point of view. The diagnosis of MFI or male factor infertility is obviously semen analysis. That's done. So we talk about semen analysis 101. Okay, so it was way back in 2010 when WHO formulated the set pattern, the protocol you need to follow while you are giving a report for a semen analysis. Nothing has changed for the last 10 or 11 years or 12 years, because now the values are the same. It is obtained by the masturbation at the clinic or at home if the person lives near the clinic. It's very important. Then he can create, then he can masturbate at his normal environment, so the sample will be much more. That's one of the issues which happens when we have a sample will delivered at the lab itself. We have to provide the semen analysis report has to provide immediate information on the quantity, that the quantity of the sperm, that quantity of ejaculate, it must not be less than 1.5 ml. Here is the problem, that is abstains from coitus. In a young individual, you tell him to come after abstaining from coitus. That can be coitus, that can be masturbation, that can be nightfalls for 2 to 3 days. Okay, for a young individual it's possible. If you give more the abstinence period, then it becomes more impossible for him. Now the one thing is very important. Often it happens that with the 2 to 3 days of abstinence, the amount ejaculated is only say 0.5 ml or 1 ml. Then comes, you have to repeat the semen analysis after say about 1 month and tell them now increase your abstinence period for 5 days, but not go beyond 7 days. What will happen with each increasing day of abstinence? The volume will going to increase. The total count often increases. But the volume is going to increase in a normal situation. But there are some problems in the morphology. So that's very important. For elderly couple, you say the period of abstinence must be about 5 days. That goes beyond. It's not a set pattern. Now, quantity is one. Quality is very important. Quality means morphology and motility. Okay. Sperm count, we used to put a lot of relevance, lot of interest in sperm count, but today with the advent of ICSI, sperm count doesn't matter at all. It's not sperm count, it's not sperm motility, it's the sperm morphology. If you can get one single live sperm, may not be motile enough, but the embryologist, if he's fit and fine, I mean, if he's learned enough, he can make the sperm active enough, motile enough to fertilize the ovum by what is known as ICSI. What is ICSI? It's called intracytoplasmic sperm injection. That is just with a micropipette, take out the single sperm and inject it into the female gamete in an in vitro situation, in vitro status. Okay, that's what is a test tube. What is a test tube baby? It's called known as a in vitro fertilization, IVF. We know there's a lot of IVF centers outside. Try to understand is something called the IUI. What is IUI? We'll come to this. What is IUI? Say your colleague, your gynecologist colleague have checked her female, I mean, they checked the female wife, I mean, female partner, the wife, and he or she has said the wife is fine from his or her point of view. Gynecological point of view, everything is fine. He has sent the husband to you as a urologist. We need to work up the male individual. You are an andrologist or urologist, you have to work up the male individual. Now you find also with all this investigation being done, the male factor is also absent. The male is also fine. So the female is fine, the male is fine. Then you have to do, after semen analysis, you have to do what is known as a postcoital test. Very important question. Short note also. What is a postcoital test? The male and the female, both they copulate in the lab. 5 minutes after the sex, you suck out by a micropipette the cervical mucus, because it has been found that cervical mucus is often the problem over here. It is thick and tenacious, and its pH is such that the alkaline environment of the spermatozoa cannot go penetrate through the cervical mucus. So one is a pH, one is also the thickness and tenacious of the cervical mucus. To circumvent this problem, we have what is known as the IUI. Very important. What is intrauterine insemination? This is insemination occurring in vivo. You're taking the ejaculated sperm, you're circumventing it through a micropipette, through an instrument, through the cervical mucus, and giving it right into the uterine cavity. Rest part of the swimming part and motility part going up to the tubes is being done by the normal spermatozoa. This is IUI. IUI pregnancy rate will be somewhat lesser with the infertile couple if you are using vis-a-vis if you are using an in vitro fertilization, IVF. What do you do in IVF? You have at least 50,000 to 5 lakhs sperm, well motile sperm. Take it outside. Take the female, pluck the female also, I mean the gamete from the ovary. That's called the egg plucking. Do it and you fertilize it in an external environment. Test tube baby, but it's not a test tube, it's done in a petri dish. Okay, but here lies another advancement of IVF is ICSI. This is the intracytoplasmic sperm injection. Where you take one sperm out of whole this game, just one sperm, tell the embryologist to wash it properly. It's called a sperm washing, adding some reagents, making it actively motile, and injecting it. So motility also not a factor because you're injecting with a micropipette right bang onto the female gamete. So it's the same thing happens. You circumvent the problem of acrosomal reaction, you circumvent the problem of capacitation. Just that the sperm has to be normal. Sperm has to be live. It must not be a teratospermic single sperm. That's all that matters. Okay. So it's very important. Collect all the ejaculate, examine within an hour, and 90% cases your job is done just seeing a semen analysis. Okay. Normal values, we talked about it. All these values, 50% motility and morphology 30 or 40%, Kruger's level 14%. These are all percentile wise. WHO says all percentile wise. Fifth percentile, the lower fifth percentile, the lower limit of the normal is taken actually as a normal limits. Okay, if you see lots of pus cell, that means that the patient is harboring some form of infection. It can be cystitis, so you have to check the urinary also. It can be a prostatitis, so you have to do an express prostate specimen and check his prostate secretions also. That's all very important. Okay, now also you have to do a semen culture. Now, what are the causes? Now let me stop my share and just go to the Google whiteboard. That will be very easy for you to understand. Is we have something which is known as the hypothalamus. Now the hypothalamus releases GnRH. Okay, it goes to the anterior pituitary and releases what is known as the LH and FSH. And these two actually acts on the testes to release testosterone. Okay, so this is it. So this is a GnRH. Okay, GnRH, and then we have what is known as the LH and FSH, and which acts on this testis to produce testosterone. Now, what really happens if there is some defect in the hypothalamic level? So the GnRH is not released. Obviously, the pituitary is not able to produce LH and FSH. Okay, so the testosterone obviously is not produced because LH FSH cannot act on the testis. So this is what is known as hypogonadotrophic hypogonadism. Okay, or higher center defect. Now tell me then what will happen in a case. What is then if you have a hypogonadotrophic hypogonadism? Obviously we have hypogonadism, testosterone level is low. Then you will be having something called the hypergonadotrophic hypogonadism. What is that? That is that the receptor level of this LH and FSH are defective. That means it's a problem in the testis itself, the gonad problem, the primary gonadal failure. So the hypothalamus will release GnRH, the pituitary will release LH FSH, but it can't act and cannot produce testosterone production. So what will the GnRH feel? I need to produce more LH FSH so that the whatever LH it will push your test. He doesn't understand whether there's a receptor failure or not. Let me produce more LH FSH so that there will be more increased testosterone. Simple thing. Okay. So here in case we have an increase in LH and FSH, but decrease in testosterone. So we have two situations. One is LH, FSH are low. We don't have GnRH as such. Testosterone is low. That is what is known as the hypogonadotrophic hypogonadism. That is the primary failure in the hypothalamus or pituitary. Or else there is a primary gonadal defect. So we have the LH FSH level is high, but the testosterone level is low. Both testosterone level is low. But again, you will have some situation where the LH FSH level is normal, the testosterone level is normal. Here means there is a defect beyond the testis called the post-testicular defects, obstructive pieces. Okay, you see that this person has azoospermia, and you check the hormone levels. You check the hormone levels, and you see that this is the problem. In the meantime, you check also the prolactin levels whenever you have hypogonadotrophic hypogonadism, because the person can have a prolactinoma, releasing prolactin in excess, pressing upon the cilia turcica and causes visual blooding. Also with hyperprolactemia, the person can have breast enlargement and a breast tenderness and galactorrhea. Simple things, boom, done. Okay, so let me stop my share and go back to my share screen once again. Right, so this is very important. Pretesticular hypothalamic causes, lot of them. There are a lot of, like, person can have anosmia called Kalman syndrome. The person can have hyperprolactinemia. Person can have taken drugs. So this is a very important. There's sulfasalazine. There is some many drugs called infertility. Then there are androgens like injectable anabolic steroids, methotrexate, cimetidine, and even nitrofurantoin that we use normally during our treatment of UTIs. Primary gonadal disorders, defect in the gonad may be due to some genetic problem as well. Klinefelter syndrome, male Turner syndrome. It's called a fertile eunuch syndrome. Okay, or else you can have some. Then we have cryptorchidism. So undescended testes can have pathologic changes. Varicoces are very common, and we'll have a different. We'll talk different varicoces causing all these problems. Drugs, as I said, part of it. Continuation. Sperm transport. You can have epididymal obstruction because cause epididymal orchitis, STDs. Okay, you can have tuberculosis. Genetic tuberculosis affects the epididymis. Vasal nodosa, vasal thickening. Also, you have ciliary transport. We have the normal ciliary motions creating this transport of the sperm. These are being destroyed in Young syndrome, cartilaginous syndrome. The patient can have a heart defect also. All these syndromes, okay, ejaculatory dysfunction, that the muscles are not properly functioning for the ejaculation. Okay, so the bulbocavernous, the ischiocavernosus. Maybe the person has had a history of of a urethroplasty being done with all the muscles being cut. Okay, without retracting the muscle to reach the site of interest in the urethroplasty, just cut the muscle and it was not held and there's been weak muscles. The person doesn't have a proper bulbocavernous, this push to the ejaculation. It's all a very important disorders of sperm transport. So we come to pre-testicular, testicular, post-testicular causes. So how you evaluate the male infertile? Very important is you also take a history. All these topics I just go very frequently because this is basically a recon course. Okay. Then you do a physical examination, examine the penis for hypospade. Is very important. The patient is unable to impregnate because he is unable to put his penis in the person's vagina for sperm transport. Okay, palpate the testes whether it's normal or not, the small infantile, okay, left less than right, whether there is cord structures, whether the vas are present, the vas may be absent, person can be having a cystic fibrosis, CFTR gene abnormality, CBAVT, that's the cystic fibrosis, then the vas difference being absence, congenital absence of the vas difference. Presence of varicocele, very important. Clinically examine the these cord structures. For varicocele, dilated tortuous veins, examine the patient standing up. Tell the patient to Valsalva maneuvers. They're all very important points. You have to list them. Okay. Secondary sexual examination, digital rectal examination is very important. Prostatitis, seminal vesiculitis. Seminal vesicle may be palpable, tender. Okay. Also, sometimes you have stones in the seminal vesicles which can be palpated. Okay, and on palpation, there can be some blood being coming out per urethral for seminal vesicle, vesiculitis, seminal vesicle cancer. All these are very rare cases, but you have to chalk it down during your history taking and investigations. So we talked about semen cultures, talked about the urologic evaluation, talked about all these things, endocrine evaluation. You do a transscrotal ultrasound if you are thinking on the line of varicoceles, renal ultrasound, because many of the cryptorchidism cases may be associated with renal abnormalities. Testicular biopsies. Now, what is testicular biopsy? That's very important. This is for sperm aspiration. Now, you may be called by a gynecologic colleague that we are having an infertile male. You have done a semen analysis and it's showing azoospermia and his hormone profiles are normal. Obviously, we're expecting a obstructive azoospermia. Now, the role of cutting through, putting in a hypodermic needle into his vas, injecting dye, seeing under CM guidance, it's known as vasography. This is totally out of practice nowadays. And then you do a vasovasostomy or a vasoepididostomy. Anastomosis are basically not done today. In only the expert centers they're doing. So basically, then you have to do what is known as the sampling of the sperm from the testes. There are different ways of sampling of the sperm. I will tell you again. Let me stop my share, go to my whiteboard. This is how you do it. This is how you do it. Let me use the eraser now. Okay. How you do it is there are 4 forms of testicular sampling. Okay. Basically, what we do, you can just put in a knife in a person's testis, the balls just like that, and he will forgive you. We have to put in the anesthesia. Okay, and then, okay, this is suppose this is the testis. Then you put a hypodermic needle on a Velflon or a Gelco, whatever, try to aspirate the material from the testis. This is known as the TESA, TESA. Okay. The second thing is this is testis, and then what we know that there is epididymis. Now I'll tell you, spermatozoa being produced. This is a factory for spermatozoa, but you cannot. But obviously you don't ejaculate every now and then. Okay, so for that, but the spermatozoa being produced continuously. The spermatogenic cycle is every 74 days. It goes to 14 stages to create a normal spermatozoa. But they have to be kept in a factory, in a go down. From a factory, they have to go to a go down, and the go down is epididymis. Epididymis is a coil structure. It has a lot of space. If you uncoil the epididymis, it becomes a lot of big, long thing, some kilometers long. So in the coil structures, the spermatozoa are being stored for whenever the ejaculation, then they go through the channel, the transport channel, and go outside to the ejaculated vas, ejaculate ducts, and urethra and out. Now, while in the epididymis, there's a lot of maturation of the spermatozoa. And the people say if you want to get mature spermatozoa in this immotile sperms, low counts, low morphology, then you have to take it from the epididymis itself. So you do the same thing from the epididymis, known as the PISA, the percutaneous aspiration or from epididymal sperm aspiration. So these are two aspirations. But you do these aspiration techniques, you find you can't find any sperm. Now the embryoologist will say, now you do something. I need your viable sperm. Then you put on your of your binoculars, that is your microscope. Okay, your microscope with a longer vision. All this neurosurgeons often use this operating microscope. That's the term I just forget. And you just see, make a small incision, and you see where is the sperm located, where the seminiferous tubules have sperms. We take it out and send it to him. This is known as the MESA, when you use a microsurgical technique. Everything fails, then you have to go for open testicular biopsy. Take a chunk of the tissue, cut open, take a chunk of the tissue, take some semen analysis, the seminiferous tubules, and send it to your embryologist. This is known as the TZ. That's you're using testicular sperm extraction, open extraction. Okay, this is an open testicular biopsy. These are the four things you have to understand. So let me stop my share and go back to my. So this is going to be a very interesting lecture. I tell you what. Okay, so this is how you evaluate azoospermia. Okay, and it's not only evaluation; it's basically treatment. Then accordingly, you have to go to ICSI procedures. Okay, ICSI, IVF procedures. IVF procedure is the broader area. Then you can have ICSI if just one sperm. Fine, he just washes and just makes it fit for the gamete. Okay, now we have the endocrine evaluation. The thing is, in ICSI, you don't have to go to these two processes. Whenever in IVF, you must have 50,000 to 5 lakh spermatozoa all around the gamete. One of them will have a capacitation. What is capacitation? Is excess amount of movement. So it goes near the zona pellucida. Okay. Then it will have bang his head on the zello pellucida and it loses acrosome. It's called the acrosomal reaction. It will release acrolein, which is a lubricant for that single spermatozoa to go to the GP3 receptors and into the perivitelline space where it can impregnate the female gamete. This is capacitance. This is acrosomal reaction. This is depends upon that particular normal healthy sperm. Once one goes, the whole thing gets shut off. It's such a very interesting phenomenon. But when you do ICSI, you don't need capacitation, you don't need acrosomal reaction. You just injected the micropipette inside the ovum and the job is done. Okay. So this is the indications. We have talked in detail about this. Genetic mutations, CFTR genes, Klinefelter syndrome. Obviously, genetic analysis is also very important. Advanced investigation, transrectal ultrasound. You see there is enlargement of the seminal vesicles is important. So you have an obstructive diagnosis in your mind. Transrectal ultrasound with Doppler for varicoceles. Testicular biopsy talked about the concept of TISA and the PISA. Now we come to what is known as a treatment. Now we already talked about treatment. If it is a hypergonadotrophic, you give pulsatile GnRH. Hypergonadotrophic, if you are left nothing but you have to do PICSI. If it's an obstructive case, then you can do all this fancy stuff called vasoepididystomy, vasovasostomy, which has very low success rates. Only in expert centers you got good success rates. Then obviously you have to think of IVF, tones or sperms. When all this fails, then you have adoption only. Pre-testicular people may have erectile dysfunction. Simple case often comes with infertility. Treat the erectile dysfunction. Patient may have some spinal injuries. Patient may have a diabetic neuropathy. Patient may be on long-term alpha blockers like this thing, sildenafil or tamsulosin or silodosin. He is having what is known as the retrograde ejaculation. He's not able to ejaculate during the act of coitus, but after that he goes to pee and he just says he has some foamy urine, nothing else. When he pees after this sex, he's basically peeing a lot of sperm along with it. So take out this post-ejaculatory sperm, post-ejaculatory urine sample, send it for analysis. Take out the urine out and see under the microscope whether it's more than 10 per high power filled spermatozoa or not. Then you have to take it for ICSI or IUI, whatever the case may be. You can treat it with Sudafed in case of the spinal injuries and diabetic patients, but often they need this artificial reproduction technique. Okay. Now, post testicular, we have talked in detail about this. So, what is the surgical treatment? But another very important thing is, if there is an obstructional level of ejaculate tract, suppose there is a stone lodged in the ejaculate tract, what can we do in those cases? Okay, the only thing is do a cystoscopy, enter with your resectoscope, just like you do a TURP. Now, in TURP, we always said don't go below the veru or piro, because it causes sphincter injury. In these cases, you are basically doing the opposite. You're cutting the veru, going right in the ejaculate duct, taking out the stone. Okay, so it often can cure your infertility problem. For patients had a urethroplasty, his muscles, that is the bulbocavernous, ischocavernous, is not strong enough. He's not able to do the last form of bulbar reflex in ejaculation. Then you need a penile vibrators, vibrative stimulation, electro ejaculation for proper assessment of ejaculation. Okay, this is the role of surgery. Future potential treatment is, obviously this is nothing much in the future potential treatment. ICSI is one. Now there are changes in the environment, in the science of infertility treatment, that you can actually put a gene, could transfer a new gene, so genetic defect, CFTR gene, AVF problem. AVF is an allospermic factor present in the long arm of chromosome Y. Those genes are problem. We can put in a normal gene into the sperm and the testis directly. This is what is known as the giant level. This is the different topic of proteomics. Different issue, not under this is the future. The future lies beyond. So global trends, as you can understand, such a big problem. You can see all of these continents are being suffering from male infertility. So this is a big problem. Proper awareness has brought this problem in the fore. Previously, 10 years down the line, 15 years before, we didn't talk much about male infertility. So obviously, talking about the society and the culture, this is very important. So the emotional impact. So the quest for having a child becomes a driving force of a couple's relationship. Here in your lives is treat with a scientific basis, with your algorithm, with your protocol, and give him a better treatment, and accordingly you treat the patient. Okay, that's all for today. That's all in basically. I will let me stop my share. So I hope you liked today's lecture. It's more of an arithmetic. Male infertility treatment is more of an arithmetic. Okay, but once you know the nuances, once you know the short things, you have to go through them over and over again. The confusion is basically dispersed, and you can basically take any question, any MCQ, or even tackle any case, clinical scenario when you're practicing. So hope you like this. Just comment on the section. I will also sending my link to my WhatsApp group and WhatsApp and also my mail ID. So you can always keep in touch. Please subscribe my channel if you haven't done so. This video is a bit long for today, but it's very important. Okay. Thank you. Bye-bye. And stay safe and be healthy.